So I thought I'd give a talk about the principles of spinal surgery, with cancers and tumors. It's, of course, a very broad topic, so I'm not going to cover everything, but I'm going to cover some basic principles that will hopefully help you guide decision-making for surgeries. So what are we talking about when we're talking about tumors? Well, I'm a very simple person. So I think about tumors in two ways. They're either a tumor that has arisen from the spine, so a primary tumor of the spine of some sort, and that's normally a bony tumor, but it could be a meningioma or anything like that that's arisen from the spine, or we're talking about a metastasis, so a secondary deposit from a breast cancer or something else like that. So first of all, how do these patients present? How do they come to us as doctors? Well, either they're a known primary, so a patient who's known to have breast cancer in the past or colorectal cancer or some cancer in the past, and they have regular checkups with their oncologists. And sometimes they get a checkup and the oncologist says, oh, we identified a tumor in the spine. So we call this an incidental or asymptomatic finding. Or, of course, they present with pain, very common finding with tumors of the spine, especially thoracic spine or lumbar spine. They come with a lot of pain. Or with neurology. So sometimes the patient says, oh, actually, I've noticed my walking has been getting less and less, and now I struggle to walk. And when you watch them, they walk with a spastic gait, so they're myelopathic, for example. Or sometimes a combination of the above. Or the other way they present is as what we call a first presentation. So they're not known to have a cancer, and they present with one of these methods that we just spoke about. And so they get investigated and we find a tumor of the spine, and then we have to investigate where the primary is from, et cetera, et cetera. So what investigations do we do? What's useful for us as doctors or as surgeons? Well, x-rays are useful. So we have something called an EOS scan. I know it's not available everywhere. Even in Australia, it's limited availability, but it's a standing scan that shows the structure of the whole spine, and you can look at things like sagittal balance, which we'll maybe go into a little bit later for my next lecture. X-rays are mostly useful, in my opinion, for mobility, so flexion extension. So an MRI scan or a CT scan doesn't tell you if there's a mobility issue or an abnormal instability, whereas a flexion extension might give you that indication. So if you put a patient in flexion, take a picture, put it in extension, take a picture, you'll see if there's any unusual translocation of the bones or the vertebra that might give you a hint as to instability of the spine. CT scan, of course, is fantastic for looking at anything bony. So if you want to look at bone quality, bone windows, bony height loss, et cetera, anything bony, the CT will give you that information. And the advantage of doing a CT is, one, you'll get the bone information, but you can also double it up with a CT chest abdo-pelvis looking for disease burden as well. A PET scan also give you an idea of disease burden. So sometimes smaller tumors won't show on a CT chest abdo-pelvis, but it will show up on a PET scan because the tumor lights up. So a PET scan is quite useful to look for disease burden. And of course, for us as surgeons, we always want an MRI scan because we want to look at the neurological tissue, and the tumor as well, of course, will show very well, especially if you give contrast in tumors that do light up with gadolinium. You'll see the disease burden from what you're going to operate on very well, and the association around the tumor. So it's not just about the tumor. What am I close to? Am I close to the spinal cord, nerve roots, an exiting nerve root, blood vessels? Remember, blood vessels are very important as well. We've had lots of talks about how blood vessels are very important. Just because you're a neurosurgeon or spinal surgeon, big, horrible blood vessels come very close to where you operate. And so we've got to be very careful of those as well. And an angio can be very useful if it's available. If you have a tumor, for example, that's very vascular, you might want to send them to the angio suite to look at what blood supply is supplying this tumor. And sometimes they can close off these little blood vessels to reduce the blood flow to the tumor. So it makes it easier for you as a surgeon. So what are when a patient comes to you, they've now come to you, they've got a spinal tumor, what options are available to you? Well, the first option, of course, is sometimes the hardest option is to say, I'm sorry, there's nothing further we can do for you. Okay, we call that palliative. So it means we're leaving you to God's grace. Okay. The other option is radiotherapy, and just radiotherapy. So sometimes if the tumor, we know what it is, maybe we've had a biopsy or the patient has a known tumor and the tumor is radiosensitive, we can say, actually, you just need to have radiotherapy. The other option, of course, is interesting for us, which is the surgery or a combination. So sometimes surgery followed by radiotherapy, and in some circumstances, we do it the other way around. We do the radiotherapy first, and then we do the surgery if we need to. So what surgical options are available to us? The simplest thing that we all know how to do, and we get taught very early in our careers, is a decompression of the spine. So a simple decompression, but we also call that separation surgery in some circumstances. And the reason why we call it separation surgery is because when you decompress, you want to take away any of the tumor burden away from the neural tissue to allow the radiotherapy to do its job with minimal harm to the neural tissue. Yes? So you take the tumor away, so we call that separation surgery. Of course, we can do stabilization surgery. So we all know about instrumentation. We can do a combination of those things. We can, if we really want to be clever, if the disease, for example, is in one vertebral body and the patient has no other disease burden, we can do an en-bloc resection. We can take away the whole vertebral body and we can augment if we need to. So what do we need to decide on? Again, so we need to go, first of all, do they need surgery or radiotherapy? We have to make these decisions. The patients come to you. You have to make that decision alongside an oncologist. And we had a lovely talk from Professor Drummond yesterday about MDTs and the importance of MDTs. And these things should go through an MDT as well. It shouldn't be a solo decision. You should have a radiation oncologist, a medical oncologist, allied health, anybody who's relevant to the patient's outcome should be there and present. So do they need surgery or radiotherapy? Do they need any surgery? Sometimes there's no surgery necessary at all. Is their spine stable? That's an important question you need to ask yourself. So this group from the States came up with what's called the NOMS framework. So that's an approach, and it's just a helpful approach to the treatment of spinal metastatic tumors. And what they came up with was this thing called NOMS, and the N stands for neurological, the O for oncological, M for medical status, and S for stability. And if you can identify these 4 factors, it gives you an idea as to whether the patient should be going for radiotherapy first, what type of radiotherapy essentially, so maybe SRS, whether they need just decompression or separation surgery or stabilization. Okay, and so I won't go through it in detail, but you can see if you follow this framework, it gives you an idea of which path the patient should follow. And things like neurological status includes myelopathy or no myelopathy for low-grade or high-grade spinal canal compression. So, of course, the oncologists, and again, I'm not going into this in any detail at all, but the oncologist will tell you there's a lot of high evidence for radiotherapy use in spinal tumors, so that we have level 1 evidence that conventional radiotherapy is recommended for palliation. And what that means is that it will help with pain. So there's good evidence that radiotherapy helps with patients with pain. So even if you're not necessarily treating them for the actual tumor, you're using the radiotherapy to help their symptoms. There is level 3 evidence for high-grade canal stenosis, that it helps with that. So not very good evidence that the radiotherapy will help with cord compression. In terms of treatment, with symptomatic spinal cord compression, so when patients have symptoms with cord compression, that conventional radiotherapy is recommended only after surgical resection. So surgical resection has a better outcome for these patients. So radiation alone only has less than a 33% chance of reversing functional deficits, whereas the surgery has a much higher chance of that. So clinical instability. So now we've got to talk about instability. So we've got to decide, we've decided whether the patient needs radiotherapy or not. Now you've got to decide, are they stable or not? Well, there's this definition by Punjabi et al. Back in 1990 as the loss of the ability of the spine under physiological load to maintain its pattern of displacement, so that there's no initial or additional neurological deficit, no major deformity, and no incapacitating pain. So pain is part of the criteria. So when we're deciding on stability for the spine with regards to tumors, there's this great score called the SIM score. And what it does is it really helps you guide as to whether the patient needs surgery, no surgery, or whether it can go either way, whether it's equivocal. So let's have a look at this. So what they look at is factors like location. Is the tumor junctional? Pain, is there pain or not? Is it a lytic lesion or a blastic lesion? Is there any sort of subluxation, or is the alignment normal, et cetera, et cetera? So there's many factors. So I'm going to show you, and what the important part is, and again, I apologize for putting this in the corner, but if you get a score from these numbers of 0 to 6, the spine is stable. You don't need to stabilize. You don't need to operate. If the score is anywhere between 7 to 12, it's potentially unstable, and you can try and manage this either way. But if the score is 13 to 18, it's unstable, and you should be considering stabilization of some sort. So let's do a quick example. Case 1. This is a 54-year-old chap who's known to have renal cell carcinoma. He presents with back pain and some minor neurological disturbance. That's the scan. So you can see this is an L3 lesion. It's lytic on CT scan, and it goes into the canal, and it's causing some compression of the nerves. Okay, so we're going to look at how that looks like on the scoreboard. So the location, we know it's L3, so it falls into this mobile spine here, so we get a 2 point for that. Pain, yes, the patient has pain, so they get 3 points. Bone lesion, it's a lytic lesion, so they get a 2. Alignment looked okay, so we give them a 0 for that. Vertebral body collapse, it was collapsed, but maybe less than 50%, so we've given him 2 for that. You could argue that it's possibly at 50%. Posterior lateral involvement, there was posterior lateral involvement on the MRI scan, so the patient gets a 1 for that because it was only a unilateral. And so the patient gets a 10 or maybe an 11, depending on which way you want to call it with the collapse. So 10 to 11 is potentially unstable. So you could operate on this patient, but you could manage this with radiotherapy and a brace if you wanted to. And I know in a lot of third world countries, that's a very viable option for a patient like this. Case 2, very quickly. So this is a 69-year-old, and I just wanted to show you this because this patient has a destructive lesion, but actually it's not lytic. This is blastic. So now if we go back to our point system, the location is semi-rigid spine because it's thoracic. The pain, yes, there's a little bit of pain, but not much. Bony lesion is 0 because it's blastic, not lytic. Vertebral body collapse, not really, a little bit. No collapse at all. Posterior lateral involvement, yes. So now they get a score of 6, which is stable. So this patient does not need any surgery. Okay. Now we're going to very quickly in the last 7 minutes or so talk about modern options for fixation of these patients. Now, for those who have it available, there's this new or relatively new thing called carbon fiber screws. What's the advantage of carbon fiber screws is that they do 2 things. One, they don't interfere with MRI imaging. So you can see this is a patient who's had normal screws on one side, and this is carbon fiber screws. So actually this patient has screws here. You just can't see them, okay? The same on the CT scan, normal screw, carbon fiber screw. And look at the artifact from this, almost nothing from here. On the MRI scan, this is the normal screw, lots of artifact. There's the carbon fiber screw. You can see the canal, and you can actually see the foramen very well on that side as well. But so one, there's an imaging advantage to having carbon fiber screws because you can follow up your patient to see if the tumor comes back, and you can see early tumor recurrence very readily. And the other thing, of course, which is the oncologists like, is the radiation. So more of the radiation will reach this patient than with normal screws because with lots of metal work, that metal work will scatter the radiation and sometimes absorb it as well. So there are advantages to using this. Now, this is not the gold standard. You don't have to do this. Normal fixation is fine. I'm just giving you an idea of what's out there in terms of some modern options. This is a patient that I did just to show you what it looks like because it does look slightly odd, but this is a patient who had to have a vertebrectomy with a cage of some sort. And these are the carbon fiber screws. And you can see these things are the tips. So it will show you where the tips of the screws are, but you can't actually see the screw at all. Completely, and here you can see the canal really well. Normally you can't. So ahead of time, Professor. In summary, first, do no harm. So remember, with any cancer patient, you've got to do what's right by the patient. Again, I referenced Professor Drummond. She gave a talk yesterday about the quality of life of patients. Don't make decisions just for what looks good on a scan or what you think you're very clever in doing. Make the right decision for the patient. So don't do any harm to the patient. Think about what the best outcome or best option for that patient is. And even if they score 15 on the SIN score, surgery might not be the right option for them. So always think about the patient first. I spoke about this again, but I'll reiterate, any patient presenting with a spinal tumor should be managed in a multidisciplinary team setting. It shouldn't be a solo decision of the oncologist. It shouldn't be a solo decision of the surgeon either. It should be a joint decision with a multidisciplinary, hence the term multidisciplinary means lots of different people from different specialties coming together to make the right decision, hopefully, for that patient. Decisions should be used on, you should use some of these frameworks because those frameworks have come from lots of data. So they have the background that many of us might not have. So when you have help available to you in the form of a framework, use it. Just the same way that if you're not confident to make a decision, you have help from somebody senior. Use that. Ask somebody who's been around for a bit longer. Yeah, it's the same principle. So you learn from somebody more experienced, and these frameworks have come from lots of data and lots of experience. Again, I'll reiterate, but careful consideration. So look at lots of factors: the patient's age, their prognosis, where do they live, what family support do they have, what disease burden they have. There's so many factors you need to think about before you make a decision. And, you know, sometimes if you don't know what to do, sometimes doing nothing might be the right thing to do. Don't jump into making a decision just because you think that you have to operate just because you're a surgeon. And when you're a surgeon, sometimes, you know, everything looks like a nail. All right. Thank you very much.